The health belief model, or HBM, stands as one of the most influential and widely utilized conceptual frameworks in health behavior research since its development way back in the 1950s. As both an explanatory model for understanding health behaviors and a guiding framework for designing interventions, the HBM has maintained its relevance through decades of health promotion research and practice. Today we'll examine the HBM's theoretical foundations, key constructs, measurement approaches, and practical applications in contemporary health promotion. We'll explore how this model helps us understand why people do or don't engage in health protective behaviors and how we can leverage this understanding to design more effective health interventions. The health belief model emerged in the 1950s through the work of social psychologists in the United States Public Health Service who were attempting to understand why people failed to participate in disease prevention and detection programs. Specifically, researchers like Hochbaum in 1958 and Rosenstock in 1960 and 1974 were investigating why so few people were participating in free tuberculosis screening programs. The theoretical underpinnings of the HBM are found in two major psychological traditions. First, there's stimulus-response theory, described by Watson in 1925, which focused on the idea that learning results from events or reinforcements that reduce physiological drives activating behavior. And second, cognitive theory, as discussed by Lewin in 1951 and Tolman in 1932, emphasized subjective expectations and the value of outcomes in determining behavior. The health belief model, or HBM, represents a value expectancy approach. It basically suggests that individuals will take health-related action if certain conditions are met. So, people are more likely to act if they value avoiding illness or, getting well. And they need to believe that a specific action will actually prevent or improve an illness. This combination of psychological perspectives really helped create a model that addresses both the cognitive aspects of decision-making and the practical elements of behavioral change when it comes to health. The health belief model comprises several primary constructs that predict why people take action regarding their health. Perceived susceptibility refers to an individual's assessment of their risk of developing a health problem. For example, you might ask yourself, how likely am I to develop breast cancer? It's important to personalize this risk, based on a person's unique characteristics or behaviors. Perceived severity is all about our beliefs regarding how serious a condition and its consequences are. You might wonder, how serious would it be if I developed breast cancer? Specifying the consequences of the risk and the condition really helps people understand the potential impact. Perceived benefits involve the belief in the effectiveness of the recommended action to reduce risk or seriousness. For instance, you could ask, will getting a mammogram help detect breast cancer early when it's more treatable? It's crucial to define exactly what action to take, and, honestly, to clarify the positive effects that action might have. Perceived barriers are, the potential negative aspects of a health action that might act as obstacles or impediments. For example, someone might wonder, will mammography be painful, expensive, or inconvenient? It's important to recognize these concerns and then work on identifying and reducing those barriers, maybe through reassurance, offering incentives, or providing some assistance. Cues to action are basically strategies or triggers that activate a person's readiness to take action, like, say, getting a reminder letter from your doctor about scheduling a mammogram. These cues can be really effective, especially when we provide how-to information, promote awareness, or send out reminders. Self-efficacy, which was added to the model back in 1988, is all about having confidence in your ability to take action. For example, you might ask yourself, am I capable of scheduling and getting a mammogram? To build self-efficacy, we can offer training, guidance, and, of course, some positive reinforcement along the way. These constructs interact in, pretty complex ways, with perceived susceptibility and severity coming together to form what we call perceived threat, while the balance between perceived benefits and perceived barriers shapes what's known as a preferred path of action. The model actually suggests certain relationships among these constructs, though honestly, they aren't always spelled out explicitly. For example, individual beliefs, like how susceptible you feel, how severe you think a condition is, what benefits you see, what barriers you anticipate, and your confidence in your abilities. These all influence your health behaviors. Modifying factors, such as demographic, socio-psychological, and structural variables, can affect these individual beliefs. Perceived threat is really just the sum of susceptibility and severity, and this combination determines how threatening a health condition seems to someone. The likelihood of taking action is, basically the benefits minus the barriers. So when benefits outweigh the barriers, taking action becomes a lot more likely. As Rosenstock put it back in 1974, combined levels of susceptibility and severity provide the energy or force to act, and the perception of benefits, minus barriers, provide a preferred path of action. Early evidence reviews, like those by Jans and Becker in 1984, found substantial empirical support for the model, and here are some key findings. Perceived barriers actually emerged as the single strongest predictor across all studies and behaviors. Perceived susceptibility was a stronger predictor for preventive behaviors than for sick role behaviors, while perceived benefits were more strongly predictive for sick role behaviors. Interestingly, perceived severity was the least powerful predictor overall, but it was still strongly related to sick role behaviors. Recent research continues to validate these relationships, though with important variations across different health behaviors and populations. Valid and reliable measurement of HBM constructs is essential for both research and application. Several principles guide effective measurement. Construct definitions must be consistent with HBM theory. Measures need to be specific to the target behavior. Measures should be relevant to the target population. Multiple items for each scale reduce measurement error. And validity and reliability should be established for each population. Exemplar champions HBM scales for breast cancer screening. These scales were originally developed in 1984 for breast self-examination. They were revised in 1993 to include self-efficacy and adapted in 1999 to be mammography-specific. So these tools have been, further adapted for culturally diverse populations, and they've even been translated into several languages like Arabic, Turkish, Korean, and Chinese. What's really impressive is their consistent reliability, with Cronbach's alpha ranging from 0.73 to 0.94. These scales really show how health belief model constructs can be operationalized and measured with strong psychometric properties, all while being adapted to different cultural contexts. Now, when we look at applications in health behavior research and interventions, breast cancer screening is a great example. Research consistently shows relationships between health belief model constructs and mammography adherence. That means, higher perceived susceptibility, higher perceived benefits, lower perceived barriers, and exposure to cues to action, especially recommendations from healthcare providers, all play important roles. The health belief model has honestly guided numerous successful interventions. Community-based applications have shown real promise. The Learn, Share, and Live program for urban minority women, for example, addressed perceptions through education sessions. lay health advisor programs also equipped peers to assess and address health belief model perceptions, which honestly can make a big difference at the community level. In medical settings, interventions often combine in-person counseling with physician letters. Telephone counseling is also used to address individualized barriers, making the support more personal and, well, a bit more accessible for many people. Minimal contact interventions can be surprisingly effective too. Tailored printed materials address specific perceived barriers, while interactive computer programs with video segments focus on individual perceptions. A consistent finding is that interventions addressing specific individual perceptions about susceptibility, benefits, barriers, and self-efficacy are more effective than generic approaches. So it's clear that a personalized touch really matters. HIV and AIDS prevention behaviors, have been a major focus for public health. The health belief model, or HBM, has been applied to understand and influence safe sex practices. So, let's take a look at what research has found in this area. There are significant relationships between perceived susceptibility and condom use in some studies. Perceived barriers, interestingly, have consistently been shown to predict condom non-use, and self-efficacy actually emerges as one of the strongest predictors of safe sex practices. When it comes to intervention applications, programs for runaway or homeless adolescents often address perceived susceptibility. Educational interventions for sex workers are designed to increase both perceived susceptibility and severity. Self-efficacy training is provided for condom use and negotiation skills. And finally, there are skills-based interventions that focus on communication and relationship dynamics. The health belief model has proven particularly valuable in addressing the complex social and interpersonal dimensions of HIV risk behaviors. Integration with other theories is becoming more common, and the health belief model is increasingly used in combination with other theoretical frameworks. For example, when we look at the trans-theoretical model, or TTM, combining HBM constructs with TTM stages of change can be really helpful. Women in pre-contemplation versus contemplation for mammography actually have different perceptions of threats, benefits, and barriers. This kind of integration allows for stage-matched interventions that address the most relevant perceptions for each group. Protection motivation theory is another important framework. By incorporating emotional components like fear, we can better understand motivation. Fear may be significantly predicted by perceived risk, benefits, and self-efficacy. And, fear, combined with barriers, may then predict actual behavior. Ecological models, really expand our focus beyond just individual perceptions. They help us consider social and environmental factors as well. By addressing these multi-level influences, we can better understand how health behaviors are shaped in real-world settings. So let's talk about some current challenges and future directions for research and application of the health belief model. One key issue is clarifying construct relationships. For instance, how exactly do susceptibility and severity combine to form a sense of threat? And are multiplicative relationships actually more predictive than additive ones? Plus, there's the question of how threat perceptions interact with perceived benefits and barriers. Another important challenge is integrating emotional components. The health belief model as it stands is primarily a cognitive model, but adding fear and other emotions might actually enhance its explanatory power. Emotional factors could play a key role in mediating the relationships between perceptions and behavior. So, let's talk about better understanding cues to action. Honestly, this construct remains pretty under-researched. Different types of cues may actually be more effective for different behaviors and populations. Plus, the timing and intensity of these cues really need further exploration. Next up, addressing social and cultural variations. HBM constructs may operate differently across cultural groups, and the model explains varying amounts of variance in behavior across populations. Culturally specific benefits and barriers, well, they definitely require tailored approaches. Now, when it comes to technological integration, HBM-guided e-health and m-health interventions are showing a lot of promise. Digital platforms allow for real-time assessment and intervention, which is pretty exciting. There's a real opportunity here for more precise tailoring of messages. So, recent research has continued to apply and expand the health belief model in, various contexts. The HBM has been widely used to understand vaccination intentions, mask wearing, and physical distancing behaviors during the pandemic. Studies have found that perceived susceptibility to COVID-19 and perceived benefits of preventive measures significantly predict adherence to guidelines. Digital health interventions like mobile health applications applying HBM constructs have shown efficacy in promoting health behaviors ranging from medication adherence to physical activity. These platforms can deliver personalized cues to action and address individual barriers in real time. Mental health applications. Well, the HBM is increasingly being applied to understand help-seeking behaviors for mental health conditions, with perceived barriers, such as stigma, emerging as particularly important predictors. So, recent meta-analyses have further confirmed the predictive validity of health belief model constructs. Perceived barriers and benefits, in particular, have consistently shown the strongest relationships with behavior across a wide range of health domains. Newer approaches are, combining health belief model constructs with concepts from behavioral economics like present bias and loss aversion. This integration helps us better understand how people actually make health decisions. Let's talk about some practical applications for health professionals. How can health professionals effectively apply the health belief model in their practice? Well, first, it's important to routinely assess key health belief model perceptions when working with patients or clients. Using validated measures whenever possible is definitely recommended. And, paying special attention to perceived barriers is crucial, since these are often the strongest predictors of behavior. Alright, so let's talk about message design. It's important to tailor communications to address the perceptions we've identified. For those folks with low perceived susceptibility, we should provide personalized risk information. And for those who do acknowledge the risk but are facing barriers, the focus really needs to be on addressing those specific obstacles. Next up is intervention development. Here the goal is to design multi-component interventions that address multiple constructs. It's a good idea to include strategies to enhance self-efficacy, like through skills training. Plus, you want to incorporate appropriate cues to action, such as reminders or follow-up communications. Now, moving on to cultural adaptation. It's crucial to assess health belief model constructs within the cultural context of the target population. Interventions should be adapted to address culturally specific perceptions. And don't forget to consider how family and community factors can influence individual perceptions. Alright, so let's talk about evaluation. First, it's important to measure changes in health belief model constructs as intermediate outcomes. Then, we need to assess whether those changes in perceptions actually mediate behavioral changes. And finally, we use these findings to refine our future intervention approaches. Now let's move on to some case studies to see the health belief model in action. Our first case study focuses on a colorectal cancer screening program. a community health center noticed, pretty low colorectal cancer screening rates among their patients aged 50 to 75. So, using the health belief model, they assessed key perceptions through a brief survey. What they found was that perceived barriers, like embarrassment and discomfort with the procedure, were really the primary obstacles. So, we designed an intervention that included a few key components. First, we created brief videos that addressed common concerns people had. Then, we made sure provider discussions focused on specific, identified barriers. We also provided clear explanations of the benefits of screening. To help out with logistics, we offered scheduling assistance. And finally, we set up reminder systems, those little cues to action that can make a big difference. As a result, screening rates increased from 35% to 62% over 12 months, which is pretty remarkable. Now, let's move on to our next example. Case Study 2, which focuses on a diabetes self-management program. So, a diabetes education program actually restructured their approach using health belief model principles. First, there was an initial assessment of patients' perceptions, including how susceptible they felt to complications, how severe they thought those potential complications could be, and what benefits they saw in self-management behaviors. The team also looked at what barriers patients faced when it came to medication adherence, healthy eating, and exercise. And finally, they assessed patients' self-efficacy for specific self-care tasks. Next, the program offered tailored education sessions that addressed each person's unique perception patterns. There was also skills training designed to build self-efficacy for blood glucose monitoring, insulin administration, and, meal planning. Plus, text message reminders were used as cues to action to help keep everyone on track. The result? Well, there were improved HbA1c levels and better self-management behaviors overall, with changes in perceived barriers and self-efficacy actually mediating these improvements. So, in conclusion, the health belief model really remains one of our most valuable frameworks for understanding health behavior and designing effective interventions. Its enduring relevance, honestly, comes from a few key factors. First, there's the intuitive logic. The constructs are just easily understood by both researchers and practitioners. Then, you have the empirical support, since decades of research have validated the predictive power of its key constructs. And let's not forget practical utility. The model translates pretty readily into concrete intervention strategies. Plus, its adaptability means it can be applied across a wide range of behaviors, populations, and settings. As we continue to face complex health challenges, the health belief model offers us a systematic way to understand why people do or don't engage in health protective behaviors. It really provides a sort of roadmap for developing interventions that address the specific perceptions driving those behaviors. By focusing on individuals' unique perceptions of susceptibility, severity, benefits, barriers, and self-efficacy, health professionals can, develop more targeted and effective approaches to promoting health behavior change. So, looking ahead, the future of the health belief model really lies in its integration with other theoretical perspectives, the incorporation of emotional components, a more sophisticated understanding of how constructs interact, and, adaptation to emerging technologies and delivery platforms. Let's dive into some discussion questions. How might the relative importance of health belief model constructs vary for different health behaviors? For example, would the same constructs predict both preventive behaviors and management of chronic conditions? How do cultural factors influence the way health belief model constructs operate? How should interventions be adapted for different cultural contexts? What are the most effective strategies for addressing perceived barriers to health behaviors in your practice setting? How can technology be leveraged to better assess health belief model constructs and deliver tailored interventions? And how might the health belief model be combined with other theoretical frameworks to create more comprehensive approaches to behavior change? All right, here's an exercise. Applying the health belief model. In small groups, select a health behavior that's relevant to your practice. Using the health belief model as a framework, identify the key perceptions, like susceptibility, severity, benefits, barriers, and self-efficacy that are likely influencing this behavior in your target population. Then, develop specific assessment questions to measure these perceptions. Next, design an intervention strategy that addresses each relevant construct. Be sure to consider how you would evaluate both changes in perceptions and in the target behavior. Finally, present your application to the larger group for discussion and feedback. Through understanding and applying the health belief model, health professionals can, develop more effective approaches to promoting health protective behaviors and ultimately improve health outcomes for the individuals and communities